Urinalysis, pulling it all together, final lecture. Urine analytes. Glucose is not normally found in the urine and is usually reabsorbed by the blood. The most common glucose seen is sugar. There are also other sugars that can be within the urine, which are lactose, fructose, galactose, and pentose. Glycosuria occurs when blood glucose levels are so high that the renal tubule glucose cannot be reabsorbed back into the bloodstream, and the renal threshold is reached. The renal threshold is 160 to 180 milligrams per deciliter. We call this when the renal threshold has been met as spilling into the urine. The enzymatic reaction on the strip is testing just for the glucose sugar. Glucose, the presence of glucose in the urine may be an indication of diabetes mellitus. It also can occur with vigorous exercise and acute emotional stress, which glucose is liberated from the liver for energy. Glucose results should be correlated with ketones to determine if insulin has been inadequate for long periods of time within the body. Glucose is increased due to the insulin not being present, or maybe there is very little present. The Clini-test is a test that detects all reducing substances. It detects all sugars, so it detects glucose, lactose, pentose, fructose, and galactose. Multi-sticks only detect glucose. The Clini-test can be used to correlate with multi-stick tests for possible detection of galactosuremia, a congenital deficiency in the body's ability to metabolize glucose to glucose. This is often seen in infants and can result in failure to thrive and possible death among these patients. Clini-test can also be used in pregnant women to detect whether lactose is present, and it can be used in people where there is a suspicion that they maybe have a diet high in honey or fruits, which then the Clini-test would detect fructose or pentose. Ketones are a product of fat metabolism. The body normally uses carbohydrates for energy, meaning sugars for energy, but if low on the carbohydrates or sugars, or there is an inadequate amount of insulin to help the body use the sugars for energy, the body will start to use fat and metabolize that for energy, which then produces ketones, and ketones can then be present in the urine. Excessive fat metabolism can lead to incomplete metabolism of fats producing the ketones. When ketone blood levels are high, it can spill over into the urine, which is called ketonuria. Correlation between uncontrolled diabetes mellitus and ketones. So if there is no insulin production, glucose cannot be metabolized for energy, so fats are then metabolized for energy, which increases ketones in the blood level, causing ketones to spill over into the urine. Other conditions for ketones in the urine are anorexia or starvation, low carbohydrate diets, excessive vomiting, fever, and some diets, some diets low in carbohydrates, which in these cases glucose would not be present. Glucose and ketones are only present usually in people who have uncontrolled diabetes. Ketones evaporate at room temperature, so urine needs to be tested immediately or capped tightly and refrigerated. Otherwise, the ketones will disappear. There is also a confirmatory test that we can do for ketones, which is called the ACE test. Blood in the urine. Blood in the urine is called hematuria. The blood in the urine can be formed from bleeding in the urinary tract caused by renal disorders such as stones, tumors, lesions, cystitis, and urethritis. Sometimes in urine specimens we can get contamination from a woman's menstrual cycle, so it is important to indicate on the lab requisition form the menstrual status of the female patient. There are 3 substances that can cause the pad to be positive for blood: intact red blood cells, hemoglobin from hemolyzed blood cells, and myoglobin, a substance like hemoglobin that transports oxygen to muscle tissue. Hemoglobinuria can be caused by transfusion reactions, malaria, drug reactions, snake bites, and severe burns. Bilirubin. The lifespan of the red blood cell is approximately 120 days. When they are lysed and release the hemoglobin, the breakdown of hemoglobin, or the heme part, produces bilirubin, which is a yellow pigment. Bilirubin must attach to a protein. Primarily, it attaches to albumin for transportation through the blood. When attached to the protein, bilirubin does not pass through the glomerulus because of a large size of the protein-bilirubin complex. Bilirubin enters the liver where it becomes water-soluble. Most of the bilirubin is then excreted through the gallbladder and intestines. When excessive levels of blood bilirubin are present, bilirubin is found in the urine. Conditions that cause excessive blood levels of bilirubin are excessive hemolysis and tissue damage, liver damage or obstruction of the bile ducts, or obstruction of the bile duct. Bilirubin gives a yellow-orange color to the urine. It also gives a yellowish tinge to skin, mucous membranes, and the whites of the eye, also called the sclera. We must be very careful to follow OSHA standards because bilirubin can be associated with hepatitis. The ICO test is a confirmatory test for bilirubin. Urobilinogen you can normally have urobilinogen present in small amounts in the urine. It is a result from the breakdown of bilirubin in the intestines by bacteria. Half of urobilinogen is reabsorbed into the blood and goes back into the liver, where it is eliminated through the body by the intestines. A small amount of urobilinogen can oftentimes be excreted by the kidneys, which is about 1%. Urobilinogen gives feces its color, and conditions that cause abnormal urobilinogen in the urine are hemolytic diseases, hepatic diseases such as cirrhosis, and sometimes infectious mononucleosis, and biliary obstructions can also cause this. Sometimes congestive heart failure, you will see an increase in urobilinogen depending on the patient's hydration status. Protein can be seen in small amounts in the urine, which can be normal. Protein molecules are usually too large to pass through the glomerulus, though. Large amounts of protein in the urine are called proteinuria, and it is the first signs of renal disease. There are 2 main proteins that are often found. One protein is albumin, which can be an indication of a pathogenic disease when it is found in the urine in large amounts. The Bence-Jones protein is also found, usually in patients with multiple myeloma. Some protein in the urine may not be pathological and is usually temporary. And in these cases, it would be fever, exposure to cold, excessive exercise, and emotional stress. Microalbumin test is sometimes ran. And a lot of times in family practice, we would run this on patients who are diabetic every so often to see if their diabetes is affecting their renal function. The microalbumin test refers to 30 to 300 milligrams of albumin a day, or we say 3.4 milligrams per millimole or less is considered negative. Anything over that is considered microalbuminuria. And typically this is found in patients that are diabetic with end-stage renal disease. We perform this test routine if a routine protein strip is negative or there may be a trace found. Microalbumin screening is critical for diabetes mellitus, like I said, patients with hypertension that is uncontrolled, heart attack patients, stroke patients, and sometimes will be ran in patients who are pregnant, and this will oftentimes indicate whether the patient has preeclampsia or not. pH measures the amount of acid or alkaline in the urine. It measures the amount of hydrogen ions in the urine. pH of 7 is considered neutral, and we think of pure water as being a neutral substance. A pH of 0 to 6 is acid or acidic in nature, and typically we think of our saliva as being 6. pH of 8 to 14 is considered alkaline, and usually our blood falls a little bit in between 7 and 8, so blood pH is 7.35 to 7.45. Our blood is very sensitive to pH, and just a little bit below or above can be life-threatening. Our urine pH is typically 5 to 8 in pH, with the average being about 6. The lungs and the kidneys are responsible for maintaining the body's acid-base balance. The blood pH must be in a range of 7.35 to 7.45. A blood pH of less than 7.35 is considered acidosis, and blood pH greater than 7.45 is considered alkalosis. Normal urine has a pH of 6.5 to about 8. Conditions causing acidic urine are diets high in protein and certain medications such as thiazide diuretics and laxative abuse can cause acidic urine. Uncontrolled diabetes can cause a more acidic urine, and also renal tuberculosis. Conditions causing an alkaline urine: diets high in vegetables, citrus fruits, milks, and other dairy products, infections such as a UTI, metabolic disorders such as cystic fibrosis, medications such as antibiotics, GERD medications, and calcium, respiratory disorders, and stale urine caused by bacteria converting urea to ammonia, and when this happens, you lose the carbon dioxide molecule. Nitrites. Nitrates in the urine may be converted to nitrites by some urinary tract bacteria. In order to see nitrites, first morning specimens is best because urine must remain in the bladder for a minimum of 4 hours for nitrates to be converted to nitrites. A positive test should be confirmed with a urine culture. The most common bacteria seen on urine culture is E. coli. The most common bacteria that converts nitrates to nitrites. Sometimes there will be a false positive result that can occur if urine is allowed to sit out too long. And we also need to correlate the nitrites with the leukocyte test reagent strip. Leukocytes, if leukocytes are present in the urine specimen that contains bacteria, this could be an indication of a UTI. When leukocytes are lysed, they release estrase. Estrase is the molecule that is present in the pad on the multi-sticks. The urinary reagent strip tests for estrase, making the strip turn purple after 2 minutes. The darker the color, the more leukocytes that are present. So here are some cases of possible urines. And so given the physical and chemical results, such as here, what microscopic results do you expect? And in this case, everything is pretty normal. As you can see, yellow in color, clarity, negative for the most part, pH is 6.5, so slightly acidic. Negative for proteins, Urobilinogen normal, nitrates and leukocytes negative, and the specific gravity is 1.010, meaning that this patient is probably pretty well hydrated, but no abnormalities seen. So given these chemical and physical results, what microscopic results do you expect to see? So color, which is red, abnormal, hazy, abnormal, blood is 3+, this would be abnormal, but everything else seems to be within normal range. So in this instance, we would think that we would see red blood cells. And since there is no white blood cells, nitrates, or any other reason, we would think that this is mainly caused from a renal disorder such as stones, tumors, or lesions. It would not be due to an infection or inflammation. Case number 3, what microscopic results do you expect to see? So hazy, typically abnormal, and then we also have positive nitrites and 1+ leukocytes. So we would expect to see white blood cells and bacteria present, and this may be an indication of a urinary tract infection, especially since we see nitrites and leukocytes. So case 4, what microscopic results do you expect to see? So abnormal, hazy, proteins 2+, also a pretty significant increase in specific gravity, really borderline for abnormal. So we might expect to see some casts. Typically casts are present when there's a high specific gravity, proteins present, and then usually a more acidic pH. So we might see some casts. And typically you might expect this in a patient that may be of excessive exercise, emotional stress, cold, fever, sometimes patients with hypertension. And if you have a patient with a high protein and a high specific gravity, if it's a female patient, are they pregnant? Is this an indicator of hypertension or preeclampsia? So correlating the patient history with the urine results is also very important. So case number 5, what microscopic results do you expect? So clarity, hazy, this would be abnormal, specific gravity is high. You might see some mucus, squamous epithelials, quite possibly some casts. Even though protein is negative, you can still see some casts, especially with a specific gravity that is high. And what microscopic results do you expect to see here? So color is red, so that is abnormal. Blood is 1+ or higher, abnormal. And then your specific gravity is kind of getting up there too. So this might be an indicator. You would obviously see some red blood cells, and this might be an indicator of renal disease. So review the results which do not correlate. So cloudy appearance really does not correlate with a low specific gravity. Typically, when clarity is cloudy, there are a lot of particles present and maybe a more concentrated urine specimen, so our specific gravity would be quite a bit higher than this. So now correlating these results, what does not match? The first thing that jumps out at me is the leukocytes here are negative, but we have 10 to 15 white blood cells in the high power field in the microscopic exam, so that does not match. And then we have a acid pH, but we have amorphous phosphate crystals, which are only present in alkaline urine. So these two also do not match. Otherwise, everything else matches pretty well. So in these results, which do not match, so some of you might pick up, well, the nitrites are negative, but the bacteria are positive. But bacteria can be positive on the microscopic exam, and on the chemical reagent strip it can be negative. And the reason this is maybe this is not a first morning specimen. Maybe the urine was not in the bladder for 4 hours prior to giving the specimen. Remember that nitrites only convert nitrates after sitting in the bladder for about 4 hours. So sometimes you will get a negative nitrite, but a positive bacteria. However, if you look at this, if there's bacteria present, more than likely leukocytes are going to be positive here. So this would not match. But the leukocytes and the reported microscopics do match. So you have to correlate sometimes and think about why these do happen. The other thing is you might say, well, protein is positive, why aren't there any casts? Just because protein is positive doesn't necessarily mean that casts are present. It may be an indication that there might be casts, but it's not always 100%. So keep those things in mind when you are doing your urine case studies.